Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. The series has published for over 32 years, and for our 9th podcast, we'll be discussing the April 2023 issue devoted to management of endocrine tumors. I'm John Vasallo, managing editor of the series here at Elsevier, and during this podcast, we will discuss 3 articles from the issue, as well as a tribute to an early leader in surgical endocrinology, Dr. Orlo Clark. Leading this discussion will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the Endocrine Tumors issue, Dr. Nancy Perrier, the Ruth and Walter Sterling Endowed Professor of Surgery and Chief of Surgical Endocrinology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Welcome to both of you, and over to you, Dr. Pollack.
Thank you, John. Really excited to be here with Dr. Perrier. And I want to start off just by congratulating Dr. Perrier on really a wonderful volume of surgical oncology clinics focusing on the management of endocrine tumors. This is really a very thorough volume that covers many of the different aspects of the management of endocrine tumors, covering medullary thyroid cancer, parathyroid carcinoma, adrenal tumors, as well as even different operative approaches to endocrine tumors, including robotic and laparoscopic developments. So this is really a tour de force, not only by Dr. Perrier, but a really wonderful group of authors that she was able to put together. So thank you so much, Nancy, for all of your hard work and for joining us on the podcast today.
Thank you. It's a pleasure to be invited and to pull and work with all the great descendants in endocrine surgery of Orlo Clark, for whom this issue is dedicated.
As John alluded to, we're going to talk today about 3 articles in particular in the volume. And what I thought we could do is start off with the first article on parathyroid carcinoma by Dr. Silva Figueroa. I thought it was important to talk about this article because parathyroid carcinoma is a fairly rare cancer. And so many of us, including myself, are not very familiar with it and about how to treat it. And so I thought maybe you could start off by talking to us a little bit just about the incidence of parathyroid carcinoma, how it presents, and maybe even a little bit about the staging of the disease.
Thank you. What a great topic to begin with, right? A little gland with a big force. So parathyroid disease in general is one of the most common endocrine tumors. Parathyroid carcinoma, however, is one of the most rare. Ironically, it's one of the most fatal. It's a disease that has a 5-year overall survival of about 80% and a 10-year overall survival of about 50%. I think the importance of this chapter and highlighting this is that this is a disease that is solely dependent on good surgery. Surgical cure is really the only designated known cure at this time. And what has happened in the last 8 to 10 years has been paramount. First of all, the 8th edition of the AJCC in 2017 acknowledged the importance of staging parathyroid carcinoma for prognostic challenge that it exists, being rare and not having enough information worldwide, and recommended prospective registration of the variables to be included in this 8th edition, which gives foresight and also the importance of us acknowledging global partnership and collaboration for rare diseases. From that development, the WHO just last year applied parathyroid carcinoma, the histopathologic criteria and biomarkers. The developments that have happened in that category have all happened within this last decade. Not only did that designation include host factors and tumor factors, but also important relevant information about the tumor microenvironment. This chapter by Dr. Angelica Kika Silver really does speak to the information that we have from large SEER databases and meta-analyses about predicting relapses and recurrences, because that really is where our finger is on the pulse in the setting of having new therapies such as immunotherapies available, but not really understanding the outcomes. So this chapter speaks to that. It speaks to this rare disease really moving forward. We know, Tim, that when we look back at prognostic variables, there are certain, host clinical variables that the chapter speaks to, such as really significant elevated calcium levels, elevated PTHs, that can partake in defining predictors of local recurrence and relapse that give us insight to whom we should initiate therapy before they develop metastatic disease, because it's the metastatic disease that really becomes difficult to manage, and patients really do succumb to the metabolic sequelae of that. So those tumor variables, the presence of angioinvasion and tumor factors and size, but also importantly, the new microenvironments that have been identified that give us information about intratumoral lymphocytes and means of initiating therapy. Of all the chapters in this book, I think this is exciting because it's rare, but there's a lot on the cusp for this oncologic tumor.
That's really helpful to know that. I was wondering if you maybe could comment a little bit more, just around the role for, radiation therapy, kind of traditional chemotherapy, if you will. And then I know you mentioned that chapter did talk a little bit about targeted therapies, and then in particular about, kind of personalized therapeutic approaches based on genomic profiling. Just maybe briefly some of the high level things that surgeons should be aware of.
Chemotherapy and radiation have not really proven to be significant contributors to extended survival in this disease. The identification of candidate driver genes such as CDC73 and things that we now have actionable, the mutations that we now can put multi-kinase inhibitors in place for are relevant for this disease. What Angelica was able to identify also is that predictors of disease-free survival, such as the lack of vascular invasion, the calcium level that presents less than 15, age actually older than 65, those are things that we would look for that would suggest shorter disease-free intervals. So that speaks to the nomogram. What speaks to the gene drivers, again, just understanding that we have mTOR and other multi-kinase inhibitors that are available that are outside of the realm of what we have traditionally had with any systemic therapy. We know that from a pathologic standpoint, identifying parafibromin staining when patients have tumors that are absent for parafibromin, that is an important prognostic indicator that gives us information about them being more aggressive.
Well, that's helpful. I mean, speaking of rare tumors, I wanted to move on to the chapter that actually you wrote with some of your colleagues on pheochromocytoma syndrome. So I was wondering if you could maybe just give our audience a brief overview of pheochromocytoma in general. And then I know this specific chapter talked about succinate dehydrogenase mutations as part of the familial pheochromocytoma syndromes. And if you could maybe shed light on that specific genotype, phenotype.
What a delight, right? When we're able to see advances and we're able to see new minds. And this particular chapter is important just because of what it represents for the next generation of endocrine leaders. So 20 years ago, we knew pheochromocytomas by the 10% rule, right? 10% are bilateral, 10% are familial. And what we now know is that that number really was an underestimate for pheochromocytomas. We know that the last decade that the number of 25% was what we really thought it was. And probably in reality, it's more like 35 or 40%. In particular, pheochromocytomas, I think the message here for the surgeons is any patient you see with a pheo really warrants genetic testing, even in the preoperative era. So that information and knowledge of that mutation is important for deciding what operation to do and how to do that operation. So in particular, we're all familiar with the RET proto-oncogene. We understand and we know about MEN2A and 2B. We know that we assimilate and consider that when we have young individuals or individuals with medullary thyroid carcinoma. But in those with pheos that are not associated with that RET oncogene, we know so much now about succinate dehydrogenase. There are 5 different mutations that are important, but in particular, the one that is most important is the one that's at highest risk for malignancy. So understanding that risk up front helps plan for a much better operation. So if a patient has an SDHB mutation, Tim, that is a patient that we, number one, would consider not proceeding with a cortical sparing operation because we wouldn't want to run the risk of any residual medullary tissue being left in situ that could develop recurrence. In addition, we know that those patients might be at a higher risk of metastatic disease potential. So we would want to consider an open operation to really, or at least a laparoscopic operation with the decision-making of looking at surrounding lymph nodes and encompassing those because we know that they're at higher risk of having lymph node metastases. We also know that they're at a much higher probability of developing metastatic disease. And in the preoperative setting, looking with FDG PET would be a superior modality for looking for metastatic disease preoperatively to better plan that operative approach. So again, this chapter just really signifies the advances of understanding what imaging to use, what operation to consider, and what other important factors to assimilate to know how to survey these patients, right? What other tumors to look for, for metachronous tumor development and for tumor development in other organs.
So just to follow up on that, you kind of alluded to a couple key points in the preoperative management of these patients, FDG PET and or DOTA PET. I was wondering if you could just briefly expound on that. And then also maybe just talk just a little bit about preoperative blockade. This is something that frequently comes up, and it's important, obviously, in the preoperative management of these patients.
The recent expansion of the radioisotopes for neuroendocrine tumors has rapidly developed. And what we know is that different mutations have different sensitivities. Particularly, it appears that FDG PET is particularly sensitive in SDHB mutations. And knowing that lets us scan the patient the right way before surgery. Historically, we also used MIBG frequently for tumors that were at high risk for synchronous mutations and for metastatic disease. But recently, we've identified that even dotatate. So, Tim, those imaging, having that preoperative information lets us perform the right test, whether it's deciding that a dotatate is better than MIBG and that deciding with SDHB, FDG PET is really better than MIBG or probably even dotatate. With your acknowledgement of the preoperative blockade, the data is sound on the cardiovascular risks of surgery, and they are higher in patients who have not been appropriately blocked with alpha blockade in particular. And that data is sound about the cardiovascular complications. So patients often present on multiple antihypertensives. An alpha blockade is not usually the first choice of a cardiologist for, routine hypertensions. So acknowledging that, preparing the patient preoperatively. And importantly, as performing these operations in a team fashion with an endocrinologist that's on board, with an anesthesiologist that's prepared and accustomed to the half-life of the drugs, to management intraoperatively, and then in the immediate postoperative setting, determining if a patient is volume depleted, whether they're bleeding, or whether this is the half-life of the preoperative drugs really is important in that perioperative management. And doing that in continuity with a team that understands what happened in those three aspects of care is really highlighted and important.
And then you, I think, briefly touched on this, but one issue that comes up is just like the operative approach, open versus minimally invasive, and what things should be considered when a surgeon is trying to decide, should I do this open or should I do this minimally invasively?
That is a topic that's even more important in adrenal cortical carcinoma than in pheochromocytoma. Our decision tree there is surgical skill set, adequacy of resection, and importantly, planning the right operation. For instance, if it's in a young adult or in a child, understanding the genetic mutation and what the risk is of that patient developing subsequent tumors helps us to define whether that patient should undergo a cortical sparing operation, right? An operation to remove the pheo, but to save portion of the cortex. If there is a possibility that they are going to develop a contralateral tumor in the future that would then render them needing an adrenalectomy on the contralateral side, right? We know that adrenal insufficiency, has a significant morbidity associated with it in follow-up. So deciding what operation and using that information up front, and then technically how to perform that. Most people comfortable with laparoscopic approaches are comfortable with most pheos until size becomes an issue with the ability to mobilize and to safely remove it without marcelating it. But the new information about SDHB and its risk and potential for malignancy gives everyone a little bit of caution in making that decision because of the necessity of there being potential lymph node deposits.
Well, we've been spending some time talking about pheochromocytoma, but obviously there's other adrenal tumors like paraganglionomas and primary hyperaldosteronism, Cushing syndrome, and adrenal cortical carcinoma. So I wanted to move on to this other chapter by Dr. Bates and Dr. Sorensen that discuss genetic testing for various adrenal tumors and what the contemporary surgeon should know. So I was wondering if you could just give us an overview when considering these various adrenal tumors and syndromes. What should the contemporary surgeon know about different genetic syndromes, profiles? What genetic testing should one be familiar with? And in general, just when you're working these patients up, what genetic testing should you be considering?
Again, just exciting to see what we now know and we didn't know a decade ago. 40% of adrenal tumors, Tim, have a component of a genetic mutation, whether it's familial adenomatous polyposis, whether it's, a child Li-Fraumoni syndrome, Beckwith-Wiedemann, whether it is someone who presents with Cushing's with an adrenal lesion. Now we know there's the gene, the PRKAR gene. I think even hyperaldosteronism, which classically we consider a small solitary adrenal lesion that just requires a straightforward adrenalectomy. We now know of 4 types of familial hyperaldosteronism, cases, and understanding which ones are likely to be familial, which ones should really just be managed medically, and which ones surgically. And I think the take home of this, great chapter by Meredith Sorensen and her colleagues is just that young patients with an adrenal lesion, consider educating them with a genetic counselor, whether it's what it looks like seemingly straightforward Cushing's. Again, understanding that the presence of a mutation is relevant in the setting that what looks like a solitary Cushing's tumor, we now know, macronodular hyperplasia. We now know, relevance to Carney's triad. These patients are more likely to have, they might have a GI stromal tumor. They might have a chondroma. But if we don't know about these, then we don't look for them. And if we don't look for them, we don't find them. And I think this is the importance of our new contemporary surgeons of understanding the mystery is always in the history, right? So it doesn't ever take us away from a good history, asking about family history of not necessarily other just adrenal tumors, but early deaths, strokes or cardiovascular events that happen, significant hypertension, significant cortisol excess. Asking about those in the family certainly lends credence to at least having a suspicion. And then really having access to a genetic counselor is important. With reference to adrenal cortical carcinoma that you mentioned, again, the understanding of that even parlays into diseases and syndromes that historically we hadn't thought usually associated with ACC. For instance, even some new data that talks to us about MEN1, which is a disease that we didn't usually assimilate with adrenal disease. But now we know that 10 to 20% of patients with MEN1 do have adrenal lesions. They're not commonly ACC, but at least looking at them and acknowledging them when we're screening the pancreas lesions in these PNETs of these patients is important. I think this chapter did a great job of awareness and of just informing the surgical community that an adrenal lesion really comes with, much more wherewithal of it being important to genetically understand whether this is a germline or even a somatic mutation, because it will and can affect treatment decisions and surveillance and follow-up.
That was a very illuminating discussion around those different topics. I wanted to conclude by asking you to comment a little bit on Dr. Orlo Clark. We know this was a special issue in that it was dedicated to Dr. Clark. Dr. Clark was one of the first surgeons who really recognized that endocrine surgery needed to be developed as a specialty outside of general surgery. And Dr. Clark, in conjunction with Dr. Norm Thompson, who I trained with, Dr. Edwin Kaplan, Dr. Jack Monchik, and Tony Edis, would start the American Association of Endocrine Surgeons. I think it's particularly appropriate that we dedicated this volume to Dr. Clark. And I know that you have firsthand experience with Dr. Clark. And like many endocrine surgeons, he left a big impression on you, Nancy. So I was wondering if you could share some personal comments and reflections, Dr. Orlo Clark.
Thank you, Tim. What a giant of a man, both in his insight to people, his insight into disease, his curiosity. As you mentioned, just the genetic profiling, the meticulous history, the attention to detail, the advances in endocrine surgery, these were things that excited him. Kwandu, Wenshin, Electron, Kabubu, many of his faculty and hundreds of mentees. The family tree of learning from him has, really sprouted around the globe. And Orlo was a giant by planting these seeds of knowledge and his passion in all of us. He was a brilliant surgeon. His scientific curiosity, his awareness of the literature, it really inspired multiple generations of surgeons. And I know that this particular book would make him proud because it is that next generation. It's a nod to his, honorific impact on the small glands that really do have so much importance. His long, skinny fingers to find parathyroid glands, really the details of lymph node dissections, the importance of always putting the patient first and being curious, I think these are all things that certainly would make him proud. His legacy is sound both in the AAES, in the IAES, which is the International Association of Endocrine Surgeons. And, his ability to bridge people together, recognizing the importance of not just being an occasionalist, because really noticing the details, but also not being an exclusionist, right? Always including and bringing people into endocrine surgery, recognizing that, it's a passing of our colleagues, both in not just in surgery, but in genetics, in medicine, in radiology, in pathology, in medical oncology. He was the soul that brought multidisciplinary people together. And really, Tim, he defined inclusion before we ever even thought of inclusion, right? He was a giant in San Francisco. Everyone was at home around him. Endocrine surgery is and has been known as, the friendly surgeons. And that is because of people like Arlo. So it's a pleasure and an honor to acknowledge him, a loss for us, but an importance of knowing that the seeds that he planted really are sprouting and have sprouted. I know he would have many questions. He was always curious about the details and many prompts for further investigation and commitment to these little glands.
Well, wonderful words for a true legend in endocrine surgery. I want to thank you again, Dr. Perrier, for this volume of Surgical Oncology Clinics and the entire team of co-authors that you brought together for this outstanding work, which I think stands as a true tribute to Dr. Clark that he indeed would be proud of. So once again, thank you, and thank all of the co-authors for your contributions. And a sincere thank you for spending time with us today on this podcast to discuss a few of the articles in particular. So thank you, Nancy. As always, a true joy.
Thank you, Dr. Pollack, and great acknowledgement, tribute, and a great team. The authors were just an incredible group of future and present leaders. So it's great to bring everyone together, and I thank you for the privilege.
Thank you for joining us for the Surgical Oncology Clinics podcast devoted to management of endocrine tumors. The 3 articles discussed, as well as 8 others, are in the April 2023 issue, Volume 32, Number 2. This series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.